Hello and welcome to the Washington AHEC podcast. My name is Jordan Johnson. I am the senior coordinator for the Southwest Washington Area Health Education Center. I'm excited to once again bring special guest Dr. Maria Yang to our conversation today. Welcome, Dr. Yang.
Hello,
How are you doing on this
I'm
fine?
doing all right.
Did you want to introduce yourself again, just in case somebody didn't catch you the first time?
Sure. Hi, everyone. My name is Maria Yang. I use she, her pronouns, and I work as a public health psychiatrist. Most of my career has been with people experiencing homelessness or cycling through different systems like jail, crisis centers, and the streets.
Very apt background then for the topic we're going to be talking about today. So very good. So let's get started. So our umbrella topic is harm reduction. And once again, I'm going to ask you for like that 10,000 foot view overview. How would you describe what is harm reduction and why is it an important topic to talk about in terms of healthcare?
Yes, so harm reduction is often associated with substance use disorders, which is not wrong. However, it can be applied more broadly. Harm reduction really is a philosophy. It is not a rigid set of rules. And my view is that it is both an end in of itself, but it is also an important engagement tool. So the phrase harm reduction pretty much describes what it is. We want to try to reduce harm. And when we're specifically talking about substances, uh, we are talking about how do we help people who are using drugs limit the amount of harm that might happen because they're using drugs. So this might include things like if people are smoking drugs using hollowed out pens, melting plastic has a lot of chemicals in it. It can cause a lot of burns and injuries. It can increase the likelihood of infection. So this is why people talk about giving out glassware when people are smoking drugs because glassware is more hygienic, it's less likely to break, you're less likely to get injuries. Um, Needle exchanges are probably the best known example of harm reduction, and it ties closely to history of Washington State. The first needle exchange was actually in Tacoma. And for those of you who may not be familiar with needle exchanges, in the 80s, HIV was epidemic in the United States, and a lot of people were dying. Like a lot of people were dying. And there was a man named David who lived in Tacoma, and he was tired of seeing people dying. So what he did is he pulled up in a truck, he pulled out a folding table, sat in a chair, and on the table were new, unused syringes. And the purpose of this was people would come with their used syringes, he would collect them safely, and people could get new syringes that were unused, no questions asked. And the purpose of this was, again, twofold, right? So to reduce harm, the first is to help reduce the spread of HIV because at this point there was some data to suggest that people who were sharing drug supplies were more likely to get HIV. And once the HIV epidemic was under better control, it came out to be like over 50% of people who were sharing needles were likely to get HIV. The second is people were using drugs, and we want people to not hurt themselves. We want people to not die. It's really hard to help people achieve those aims if you are shaming them and ostracizing them. So this was also an opportunity for David and others to get to know people who were using drugs in the community and have conversations with them about it. Why are you using drugs? What do you get out of using drugs? What do you like about using drugs? Are drugs causing you any problems? And if we want people to change their behavior, and if you are in healthcare, you on some level believe that people can change their behavior because otherwise you wouldn't be in this job. Uh, People want to learn more about their health. People want to know about risks and benefits, particularly if they're coming to you. If people don't want to talk to you or they think that you have an agenda that you're going to push without taking them into consideration, they are not going to come and talk to you. So the fact that someone's willing to come to talk to you, even though they are using drugs or drinking a lot of alcohol or whatever the case may be, that means on some level they are ambivalent. So harm reduction, again, is also an approach to engage people so you can have more conversations. So If and when they are ready to change, they will talk to you about it, and you can use that window to try to nudge them. Again, you can't make people do things, but you can nudge them in a direction where they might be more likely to make changes to improve their own health.
Awesome, man. There's a lot of information you threw at me, and I was trying to take notes so I can go back and piece one by one. So thank you for sharing all that. I was not aware of the history of that, and especially here in the greater Seattle Tacoma area, having like in our own backyard is where the needle exchange program started. That's fascinating. Um, I want to also mention in one of our correspondence before we started today, you actually mentioned the example of like seatbelt use as an example of harm reduction. So like here's our extreme examples of like um, reducing harm in terms of those who use substances, but also like some other behaviors. It's a mindset approach to reducing harm. Could you speak on that a little bit about like maybe some other contexts in which harm reduction is something that is employed?
Absolutely. And it's always fun for groups to get together and come up with their own unique examples of harm reduction because we see it everywhere. So, driving a car is dangerous, especially the bigger the car, the more likely there's going to be injuries and deaths. If you want to reduce the likelihood that you are going to die from a car crash, you will not drive a car, right? Because the risk of dying from a car crash is greater than dying in a bus crash, greater than dying from a plane crash. And yet, almost everyone drives a car at some point, rides in a car at some point. So uh, we take it so for granted that we don't think about seatbelts being a form of harm reduction. So if you're going to drive around in a car, which a lot of people do, you could drive around without a seatbelt on. And there was a time not that long ago where seatbelts weren't actually part of the law. So people were driving around in cars, they got into car crashes, because of not even because of something terrible like somebody was drinking and then they got into a car. Just things happen. And people were dying. Young people were dying, old people were dying, parents, friends. So people invented seatbelts because if you wore a seatbelt, you're less likely to die. And then they invented airbags, so you're less likely to die. So these interventions, they don't seem like they're harm reduction. However, they totally are, and they're actually encapsulated in the law in most states where you are required to wear a seatbelt or you can get ticketed. Another example are condoms. So condoms, there's two ways to look at it. So one is sexually transmitted infections, right? So people, when they have sex and they wear condoms, that is reducing harm. The best way to not get a sexually transmitted infection and the best way to not get pregnant is to not have sex. And people like to have sex. So condoms are a form of harm reduction. Not to say that pregnancy is harm. However, if you're not ready to have a kid, or that's not like something that you want ever in your life, like condoms are a form of harm reduction. So again, tying it back to substance use, which is where it usually originates from, it's both an end in of itself, but it's also an opportunity to have conversation. So, for example, to not talk about drugs, if I am, we've all seen now those tables where there's a giant jar filled with condoms, right? If I'm sitting at a table at a fair and I'm sitting next to a giant jar of condoms, I can offer people condoms, and some people, particularly people who might be like 12 or 13, they'll be like, "Tee, hee, hee, I don't want to take a condom." And like, what an opportunity to have a conversation about, hey, people can get infections, and some of them are kind of gnarly. And some of them can last a long time. Like, we don't want people getting HIV. HIV is now considered a chronic condition. Do you want to live with a chronic condition? You don't? Okay, well, here's a condom, and this is how you use it. But also for women and girls, this is an opportunity for you to learn about how to not get pregnant. You may have heard about the rhythm method, and there's lots of styles, including withdrawal, but those are just not as good as condoms at preventing pregnancy. So having this giant jar of condoms, often in ridiculous colors, it's an opportunity to engage with people. So offering glassware, offering needles, that is also an opportunity. I really want to make a very clear point here, though, because sometimes people think harm reduction is enablement, which it could look that way. So there is some responsibility on the person who's offering harm reduction to broach the conversation about the behavior, right? So if I'm just sitting at a table and I have a whole bunch of glassware and needles in front of me, and I'm just like, yeah, give me your needles and here, take some glassware. I mean, that's like, That is a very basic level of harm reduction. However, very short ways to engage in this conversation without being pushy, without being, like not proselytizing, it's just thanking people. So you'll often hear me say again and again, a lot of people who are coming from excluded communities, immigrants, refugees, people who use drugs, people who are trans, they so rarely hear what they are doing well. So if you are at a needle exchange and someone comes up to exchange their needles, what an opportunity to say, hey, you know what? Thanks so much for taking care of your health. They're going to look at you like you're a weirdo and like, but they might come back and be like, hey, that Maria, she's super weird because she always thanks me for taking care of my health. But like nobody else says that. And maybe next time someone will be like, why do you keep thanking me for taking care of my health? And then I can say, well, you're doing a great job of not, you're doing a great job of protecting people from getting HIV, including yourself. And I'll just leave it there. And people might be like, well, I wasn't going to get HIV anyway. Like, I don't know what you're talking about. But like that is how you build a relationship, right? So harm reduction both is an end in of itself, but it's also an opportunity to engage people in conversations because this person who's been coming to the needle exchange for a year, for 2 years, one day they might come by and say, you know what? Um, I think I want to learn more about Suboxone. And you're a doctor. Can you tell me about Suboxone? And it might take 2 years. It might take five. It might take 6 months. But if I'm like, you are a terrible person for using drugs, we're not going to give you any needles because you're a terrible person making terrible decisions. If they ever hear about Suboxone, they're never going to come back and talk to me about it because they're going to think that Dr. Yang is very mean. She's like every other doctor I've ever met, and I don't ever want to talk to her. But if we instead just plant little seeds and provide little bits of education, even if people think we're weird, we're opening the door for people to come back to us in the future so that we can actually help improve their health. It's not just poor people who are outside who might be not white. Harm reduction can apply to literally any segment of the population. We just tend to focus on certain populations. So harm reduction conversations. So for those of you who might end up working in rural communities, but the income inequality isn't that great, there are so many opportunities to have harm reduction conversations with your patients, even in settings where there's not urban homelessness. So let's just say you're working in a farm community and there's people with diabetes and they are just not into checking their blood sugar and they are not into checking, not in addition to not checking their blood sugar, they are like not interested in insulin. They're freaked out about the idea of having to poke themselves. So like there's a harm reduction conversation right there, right? Like so instead of checking your blood sugar 3 times a day or 4 times a day, okay, you checked it twice this week. Amazing. What was it like for you to check it twice that week? Was it really scary? Did you have a freak out because of the numbers? Okay, well, let's talk about that. And maybe like instead of twice a week, can we make it 3 times a week, right? Like you can apply harm reduction principles to so many things in healthcare.
Humans are going to human. They're going to engage in certain behaviors that maybe some people don't think they should be engaging in. Like there's this sociocultural expectation about certain demographics to whom these things should be applied. And I really enjoy bringing this component back out to like, it doesn't apply only to those sociocultural demographics. It can really apply to anyone. So thank you for bringing that out. I really am enjoying hearing what you have to say on this topic. So since you mentioned principles of harm reduction, now we've kind of talked about, again, the philosophy of it and why it's super important. Are there some like very specific principles that current and future healthcare providers could adopt, or behaviors, or what would be a practical thing you would mention to current and future providers about how to approach harm reduction in their practice?
Yeah, thanks for that question. And you've actually already commented on it earlier when you said humans are going to human, right? And there's two ideas in that statement. So one is humans are human, right? So there might be people who have different political beliefs than you, who might spend their money differently, who might come from a different background. They are still a person. So much of the philosophy of harm reduction is remembering that this is a person in front of you and they might be making choices that you don't agree with. However, they are a person, so there's reasons why they're making those decisions. So what an opportunity to learn more about like what's happening to you, and not necessarily bad things, right? Like what's happening to you that this is the choice that you're making right now, and let me just be curious about it. The second is there's the world that we want to live in, and then there's the world we actually live in, right? So people are going to make choices that you just do not agree with.
As I'm continuing learning more and more about this topic, it really does just hammer in that point that like the first thing you need to care about is the human being in front of you. Like that is the number one thing. What does this person need right now to get by? And really, it requires the person, whether you're a healthcare professional or not, to kind of check your biases at the door. To, maybe you wouldn't have gone down that path, but what is this person right in front of you? What do they need right in this moment? And that would be the way that you would approach dealing with them.
Mhm.
Yeah. What would you say? Are there like resources that people can access that would help them maybe learn more about people experiencing homelessness or people who are engaged in using substances? Is there like places that you could go or communities you could interact with or places that you could learn more information to be better informed about how to interact with people from those communities?
Yeah, first of all, the National Harm Reduction Coalition, pretty good website, comprehensive, easy to use, clear about messaging. So, I mean, the internet is a huge playground, and some of it's terrible, some of it's good. National Harm Reduction Coalition has legit information on there. Uh, I think there's my recommendation to students of all ages and training is there's always two ways to go about learning things. So, in the settings that all of you are training in right now, you work with a variety of professionals, and some of them have opinions that you absolutely do not agree with and styles that you do not agree with. So, let's just say that this is your first time hearing about harm reduction. Maybe it seems really strange. Like, well, it seems like we're just enabling people to use drugs, and I don't want to do that because that doesn't seem like that's my job. That's a totally fair impression to get and lean into that. So if you encounter professors who are working with populations who are using drugs or drinking alcohol, which, like, to be fair, is literally everyone. It just means the patient hasn't told you yet, because everyone has, well, if you haven't yet encountered one person who's using drugs or drinking a lot of alcohol, you will. And learning from your professors who lean into that, like, how does this person talk to this person? How does this person affirm the decisions that patients are making in the moment? How might they be using language to help patients make different choices? You might also hear some professors who will say things that will be appalling, like, yeah, you know what? Like, if meth is helping you feel better, then maybe you should just use meth. Like, I don't think anyone's ever going to say it quite like that, but you will have times where you hear something and maybe the person's having a bad day, or maybe that's just what they believe. There's some professor out of Columbia University who's written a book about how he uses heroin. Like, this is like a legit professor of Columbia University, and he's a big proponent of people should use drugs. The war on drugs has been too harsh. I actually agree with the second phrasing because of some of the racial and socioeconomic forces behind it. And like, if people say things like ask questions as you're going through training, like tell me more about that point of view. Tell me about your experiences with patients who use drugs. Tell me about what's worked for you and what's not worked for you. The flip side is maybe some of you are very familiar with harm reduction. Maybe you've spent time with the People's Harm Reduction Alliance. That's an organization here in Seattle that is very much on the front lines of harm reduction and needle exchange. For those of you in Seattle, King County, our county government, King County, operates a needle exchange, and for a while, it was actually in multiple locations, but now I think it's just in downtown Seattle. So maybe you come from a community where you're very, very familiar with harm reduction. Listen and talk to people who believe in abstinence-based only programming, right? So people have opinions about this. So find out more about, well, tell me more about your views of abstinence. Tell me how that's worked for certain people, how maybe it's not worked for certain people. People often tie morality into this. Find out more about that viewpoint. And the reason why I say this is for a few reasons. One is harm reduction is a continuum. So on one end are people who are absolutely not interested in stopping drinking, stopping using drugs for whatever reason or reasons. On the other end is, in fact, abstinence. There are people who So for all these people who are now not using drugs, there was a time when they were, and they stopped, and they went through whatever process they went through to decide to stop, right? So that the fact that this person exists shows that it's a continuum. So you don't know if the person in front of you is actually one day going to completely stop using. But if you go in with the lens of like, abstinence is terrible and only XYZ people pursue abstinence, this person who one day might want abstinence may stop talking to you, right? So just you want to get a viewpoint or viewpoints about how abstinence works for some people. The flip side is there are people who absolutely do not use drugs right now, and one day they might start using for whatever reason. Cannabis happens to be legal in the state of Washington. So there are people who are going to try using cannabis and they will like it, and they are not going to use it to excess. They will figure out a way to have it be useful in their lives without ruining or overtaking their lives. And if they find out that you're a person who's like abstinence only, they're not going to talk to you about their cannabis use, even though one day they might start hearing voices, they might have a panic attack. They're not going to want to talk to you about that. So learning about this whole spectrum of harm reduction, which again extends from using and just not being ready to stop to people who used to use and they stopped completely, it is a continuum, and learning about all those different perspectives is what's going to help you be effective. A point I often like to make when we talk about these sorts of things is there are instances where you can be right and you can be effective. And there might be instances where it's much more useful for your patient if you are effective and not clinging to what is right. Do I want people to be snorting and smoking and injecting fentanyl? No. I have seen how it has ruined lives. However, if I am insisting like you are wrong to be using fentanyl, that doesn't make me effective, even though I might be right. So I'm going to let go of being right and just ask, what do you like about fentanyl? Tell me more about that. Right. And then when people start telling me, like, I don't necessarily like it, I just don't want to go through withdrawal anymore, then we can start talking about, like, okay, well, what are you doing now to prevent withdrawal? What are some things that you've heard about that might help you not go through withdrawal? Do you want to hear about some other options? Right. Like that way, it's both an end in of itself and also opening the door for engagement.
Yeah, that's really fascinating. That the whole thinking about harm reduction as continuum, like something I think about is if you take two people, one person, they drink a beer on Saturday afternoon after doing a hard day of work in the yard, compared to somebody who partakes of multiple alcoholic drinks per day and is usually in that state of inebriation. What's the difference between those two people on that spectrum? And then if you're curious about that, then that kind of causes you to start looking into some of more of the, there's sociocultural and political reasons why the difference between those two individuals. And historically, we have focused so much on the individual. Like there's something wrong with you that's broken with you that caused you to drink to the point of being totally unable to participate in society. Um, so yeah, I really appreciate that, thinking about it as a continuum. Um, so then, but what you're saying though, as a provider, is maybe having that curiosity would help you work with somebody where for that person to kind of to be able to like engage in more socially positive behaviors that they might need to look to stop using fentanyl was the example that you gave. As a provider, you're in the position to maybe try to help springboard that person into that. Because I think like I hear a lot of people, kind of very disparaging will say people on the street and they've made poor choices and they this and that reason. But actually, for us as members of society who care about other people, that would and we should inform ourselves even more so about all of the different reasons, the contributing factors to why a person gets to that point, rather than just write them off and say, oh, they made poor choices in their life.
Yeah, and I appreciate your focus on the language that you're using. I think the point I'm trying to make here is we can talk about included populations and excluded populations. Ultimately, everybody at some point belongs to an excluded population, right? So um, when we talk about excluded populations right now, and I know this might just sound like jargon, and to get around this idea of, certain uh, authorities talk about members who are or are not contributing to society. And we can talk about excluded and included populations. And that might be a little easier to wrap our heads around. So there are people who do not have a stable place to live and they follow rules, they pay their bus fare, they walk into a grocery store and because they haven't been able to take a shower in a week, security starts following them around the grocery store, even though they have money, they have an EBT card, or they have money, and they're going to buy the groceries. And we talk about these individuals being part of an excluded population because for the rest of us, we can walk into a grocery store and we're not largely not going to be followed around, right? But solely because this person is dressed a certain way, maybe they don't smell the freshest, they get excluded. And so and nobody wants to be followed around the grocery store, like especially when you're just there to buy food and pay for your food and get out. Are there people who are making choices that are harming other people and they don't care? Yes. Is that the vast majority of people? No. So I also don't want people taken away from this conversation that Dr. Yang thinks everybody's an angel and everybody's perfect and everything is fine. For those of us who work in healthcare, having professional curiosity is valuable. For people who are not in healthcare, having curiosity about people and their backstories, that can go a long way in contributing to community and to peace. It's not going to fix everything, but again, going back to what you said initially, humans are going to human, and we have to look at humans as humans.
This topic, I'm getting very much more of like the first big hurdle to climb is just kind of overcoming that. Historically, we have viewed certain behaviors as socially unacceptable, and in turn, the only proper way to handle people who engage in those behaviors is being total abstinence. And it's kind of this transformation that we have to make on an individual level and on a societal level to approach that every human deserves the same level of care and community care and focus and treatment and healthcare regardless of if whether or not they do things that we might personally disagree with. Um, and it's not so much like that the next step is okay, then I'm gonna be the great, fantastic doctor, wonderful doctor that I am to all of my patients, regardless where they come back from. So it's very much more this conversation is like really that first major hurdle of getting over kind of the societal rhetoric that we've approached this topic with in the past.
I think yes. And to build on something that you said earlier about social and cultural views, and this ties very much into harm reduction. And I know sometimes people they tire of hearing about certain ethnic groups, racial groups getting or not getting attention and resources, and it's very relevant. So for students right now, you have grown up in an environment where opioid use is considered a public health emergency or crisis, right? So all this effort to get buprenorphine out, all these efforts to try to help people um, stop using drugs, reduce their use, reduce harm. So Black people were using opioids in the 60s and 70s, and nobody cared. It was not considered a public health emergency. It was considered criminal behavior. For those of you who are familiar with opioid treatment, part of the reason why methadone clinics are so regulated is because methadone came up in the late 60s and 70s. Uh, Not a lot of white people, there were white people using opioids. However, it was part of the continuum of the criminal legal system. But now that like white kids in suburbs were using opioids and dying from overdoses, that's when it became a public health crisis, not when Black people in particular, and certainly Chinese people 100 years ago during the Opium Wars, it wasn't considered a public health issue then. So this again goes back to the idea of harm reduction as viewing people as people. If you view certain racial groups as not being people, then it's not going to be a public health crisis. But now that we've framed it as a public health crisis, we can actually look at the people who are using drugs as people.
So really, when we have this discussion on harm reduction, there's the personal, there's the social aspect, there's the political activism aspect. Um, how do you wrap your mind around the work to be done here?
And this is why like talking about harm reduction, it's not a subject for a lecture. It actually is a subject for
And for
conversation
discussion,
because
yeah.
there are nuances to it. So what I will
Yeah.
say is when people are thinking about harm reduction or you're relatively new to it, sometimes people they start scoping out to broad systems level, which some people are wired that way, and that's great. Jordan, you actually gave a really nice example the last time we spoke about there are lifeguards who save
Mhm.
individual people, and then there's the people who design the pool, right? So we need both because accidents happen and some random person is going to end up being in distress. So we want a lifeguard. However, if the pool's poorly designed, no lifeguard is going to be able to save as many people as they could, right? So there is a tension between the big system level and the individual level. A lot of students right now, you are busy learning how to be the professional that you're going to be, and that takes a lot of time. Thank you so much for taking the time to learn your craft. And you might be like, I don't like, I'm interested in doing something on the bigger picture, but I don't know what to do. And I've got like all this homework, plus I'm raising a family. Maybe you've got other things going on in your life. So just to reduce some of the pressure, because you are going through school is hard work. Like there's just so much reading and like you don't know what you don't know. And then people are asking you questions and it's like it's a lot. Like let's accept that being in school is a lot and we can't expect everyone to do everything. If you are interested in harm reduction or you're interested in more just in like applying it and maybe like the harm reduction coalition sounds interesting to you, but now is not the time, which is totally understandable. There are things you can do within your 6 foot radius that are going to promote harm reduction principles. It does not have to be flashy or big. So the next time when you're in clinic or you're in an inpatient unit and there is a person who is is homeless or they are clearly having psychiatric symptoms or they come in and they live in a house, but it becomes clear that they're going through alcohol withdrawal. One of the best ways that you can exhibit the principles of harm reduction is to talk to that person like a person. So, and talk to your colleagues like that person is a person. So, we've all heard faculty and staff and our colleagues say things like, oh, yeah, like that's the alcohol guy in room one. Like, that's not the alcohol guy. You can say, like, that's Mr. Smith in room one. And we're just trying to figure out what's going on to minimize his withdrawal. That actually goes a huge long way. Instead of saying, like, oh, that's the alcohol guy, that's the HIV guy, that's the fentanyl guy. Like, these are actually people with names. Try using their names, right? Or if you have a colleague who comes in and is like, gosh, I'm so tired of these people who just keep using drugs. Like, it's so awful. You can validate that emotion, like, hey, that's really frustrating. And I'm wondering what's going on with that guy that this is his best choice. That will nip that conversation in the bud because all of your colleagues will be like, oh, I didn't even think about that, right? Or if they like decide to talk back and be like, no, this person's making terrible conversation or making terrible choices, you can choose at that point whether you want to have that conversation. But even just making that one comment like, gosh, I wonder what happened that this seems to them to be the best choice, right? Like just offering the opportunity to pause and wonder what is happening to this person or what happened to this person, right? And that might help this colleague or faculty, whoever, the next time they talk to this person, maybe adopt a better tone. And that takes no time. That takes literally 5 seconds. You said one thing. Might your colleagues be like, oh, well, you're being a goody two shoes and you're being really naive? Sure, but do you want to err on the side of being cynical or do you want to believe that people can change? Because again, you work in healthcare. So on some level, you have to believe people can change. So these little advocacy pieces, totally doable, influences people within your 6 foot radius. Your patients will know. They will sense like this person is not calling me the alcohol guy. They are using my name. They will know, and they might be a little more likely to talk to you about what's going on with them. And they might ask, like, I'm tired of drinking. It's really embarrassing. They might not say that, but you don't know until you try.
In that way, it does go back to verbal de-escalation, where when you first approach the patient, you're not thinking this is the alcohol guy. You're thinking this is a human being who deserves my best care and attention I can give to them. Well, thank you, Dr. Yang. I think there's some fantastic discussion here. If you had one thing, and I know we've said a lot of, there's like 25 one-line snippets I could take out of this and be perfect. But if you had one thing to say to somebody, if you could whisper into their brains for a minute and say something you want to say on this topic, what would it be?
It is a privilege to be able to provide healthcare to people. I know there are times when it does not feel like that's the case. I feel those moments still too, to this day. Um, and you have the opportunity to help people improve their quality of life so that they can do the things that they want to do. And to help people improve the quality of their life, it helps to get to know them as a person. I know sometimes you don't have the time to do that. You often don't have the time to do that. And you just taking the time to say, hi, it's nice to see you, looking people in the eye, just trying to learn one thing about them that's not related solely to their health. Um, Treating people like people. I know I've said that a lot, and uh, there's so much pressure, and there's a lot of not just within the system, but also social pressure to write certain people off. And the moment you treat someone like a person, often you'll find that the outcome will turn out better than you expected.